Good evening, everyone, and welcome to this webinar hosted by the Melbourne School of Health Sciences. I'm Associate Professor Jenny McGinley, Head of the Department of Physiotherapy, and I'm delighted to welcome you here this evening. As we come here together tonight, we're gathered on many lands across Australia and beyond. I'd like to acknowledge the first and continuing custodians of Melbourne, the Wurundjeri people of the Greater Kulin Nation. I offer respect to their elders, past and present, and to all Aboriginal and Torres Strait Islander people who may be with us this evening. I am delighted to see so many of you, many familiar names and faces from our alumni and some of our future alumni. This evening, we'll be exploring the topic of how sports medicine can return to play in a mid or post-pandemic world. So without further ado, I'll now hand over to Dr. Sonia Moore to commence the proceedings. I hope you enjoy this evening. Thank you.
Thank you, Jenny, and good evening all. I'm Sonia Moore and I'll be your host for tonight's exciting panel discussion on return to play, wellbeing and performance. With me tonight are four wonderful speakers from the sports medicine world, and I thank them generously for agreeing to be here tonight. Throughout the evening, I'll call on the panellists to introduce themselves. Once again, welcome to this evening's session. And before we hear from each of our panellists in turn, I would like to speak a little bit about what return to play might look like in the real world and some of the scenarios we need to consider. What we'd like to present this evening is not a recipe for return to play decisions, but we'd like to present the complexity of this, some of our insights and some guidance and frameworks about how we can approach these decisions, including how to organise our thoughts and the process that we can go about. So firstly, what is your end game? As I share some of my experiences and you listen to the speakers this evening, think about your own clinical practice and the athletes in your care and the setting that you're in. I'd like you to think about this from the perspective of your role and what you're there to do and how you can support them. This includes your goals in terms of how you see yourself as a clinician, and this is your end game. Most importantly, when we're talking about return to play decisions, what's the end game for our athlete? What does their sport look like? And what are you returning them to? Because the demands and situations that they're returning to are going to change what you do with them, change your plan and change your decisions. So both in your own learning and in return to play decisions, we're going to look at this from the perspective of planning with the end game in mind. So that's what this paper is about. It's about progressing rehabilitation in a graduated and controlled way towards a full return to play. So what the authors term as chaos refers to unpredictable behaviours and patterns, which are characteristic of the demands of gameplay sport. And I think most athletes and coaches would contest the idea that their strategic game plans or their well-practiced race plans are referred to in any way as chaos. But what this really explains is the continuum approach to injury rehabilitation, beginning with controlled early movement and following a structured and graduated progression towards random and reactive skill execution. And one thing it is fair to say is that there's no place for chaos in sports medicine, particularly in relation to return to play decisions. So what we're aiming to do in sports medicine is account for and plan for this high chaos end game. In controlling what we can place a higher level of structure around the chaos and reduce it. That is, the more familiar we can make it, the less unpredictable it becomes. And by definition, it's less chaotic. So we need to scrutinise the end game and the demands, identify the typical and the unpredictable behaviours and patterns, and account for these and plan for them. We need to prepare for challenges and contests, anticipate the risks, plan for them to the extent of having a response plan should they arise, but then mitigate and circumvent the risk where you can. And these things help us contain the chaos to the sport, not at all adding to it with a chaotic sports medicine approach. With rehabilitation decisions, we're afforded the increased luxury of planning often. Field of play or game day decisions, these often need to be made quickly and in a prioritised way. Can this athlete safely continue, or do they need to leave the field of play? And very often we need to be a controlled voice of reason in an otherwise chaotic or emotionally charged or high adrenaline situation. And having first earned the trust to deliver these kinds of messages and have them well received is also very important. So my end game scenario here that I'd like to share with you is is this athlete at the Commonwealth Games on the Gold Coast. We had a few minutes to decide whether or not he could take his final jumps, with the camera projecting onto the big screen a few inches from our faces. People might be tempted to say this is a more important decision given a gold medal was on the line, but regardless of the situation, the decision needs to be based on evidence and best practice models for that particular injury. And also communicating and synthesizing that key information in a short space of time becomes really important. So composure is a strong trait of this gold medal athlete. And when I asked him how he's managing in our COVID environment and for his permission to share these pictures this evening, he said 1000%. COVID is testing our patience, but with snow forecast in Chicago, it's going to be harder to train. So reinforcing that amongst the chaos, the end game for him remains so clearly in focus. In community sport, the end game here was to return young athletes to participating and enjoying their sport. So in a post-COVID or a COVID-safe environment, we still need to have that similar approach, which is to curate the best available evidence, guidelines and resources, and be up to date with a changing environment. And once again, proactively anticipating what might come next. So these are some resources that you might like to follow up after this evening. And my advice is not just to appreciate the theory and the guidelines, but also to consider how you can make this return to play happen for real at your club in your situation. So at my club, at Northcote Junior Footy Club in Melbourne, this is what our return to play plan looks like in a COVID-safe environment. We had several people protocols. We had one for parents and coaches and players, so everyone understood what was expected of them and also in line with the COVID compliance guidelines. We had an equipment management protocol, and that involved things like sanitising footies and other equipment and the like. We had a ground management protocol, and that involved everyone being aware of entry and exit points to the ground and an exclusion zone in the middle. And that allowed us to be compliant with the small group trainings. And the numbers could vary depending on what the protocol was at any point in time. For me, a big thing was the COVID safe medical kits and the trainers kits. We needed to have a look at these and make sure everything in there as much as possible was single use and certainly easily cleanable, easily sanitisable. And certainly don't roll the dice with what I'm going to call fomites in my usual favourite kit, with a fomite being an object or a material which is likely to carry infection. So this is another example of how we need to be open and receptive to change and ready to rapidly respond to changing needs rather than doing what we're comfortable with and what we've always done. So as always, there's a contingency. We have 17 teams in my club, and so there's 18 trainers kits because you never know what's going to happen next. When we come to planned rehabilitation, there's little excuse for this to be chaos. There are several domains that need to be considered in return to play planning, and these are just some examples of them. So we have pain management, musculoskeletal factors or the timeline post-injury, psychological readiness, physical readiness, and some sport performance indicators. And often we separate these so that we can critically assess them or reason through them or plan them. And sometimes we separate them also so we can get the best person with the right expertise to assist with the management. But really when we need to make a return to play decision, we need to build these back together and consider the athlete as a whole person and their situation. For example, athlete on the left may be about 50% of where we'd like them to be in terms of pain, and they might be quite worried about returning, while their timeline post-injury and their physical tests are actually quite good. The athlete on the right, they may be pain-free or be disregarding their pain and ready and raring to play whatever it takes. But we can see that they're not ready in terms of injury recovery or their training performance. So we need to consider why these athletes are ready or why they may not be ready, and also what constitutes acceptable readiness in each of these domains. Because we don't expect anyone to be perfect, but maybe a perfect 10 is required for a return to play. We need to consider what the end game is. So I make no criticism here of spotting in gymnastics, but if my athlete's out there and I feel like I need to wait and catch their fall, I perhaps need to rethink that decision. So as we move through this evening, we'll explore some of the evidence and reasoning that can help you make good, well-informed, defensible decisions. By defensible, I mean that you could explain really clearly to someone how and why this athlete is ready to return to play, or not ready as it may be. how and why the governance, procedures and equipment you have in place supports the safe environment. For example, a COVID compliant or COVID safe approach. So once again, picture yourself in your club or clinic. What is chaos? What can you control? And how do some of the perspectives that we speak through this evening fit with the athletes in your care? So it's on this note that I'd like to introduce Kylie Turton. And Kylie's going to talk about some of the clinical reasoning and decision-making frameworks that will help us think through organising the evidence and organising our thoughts about return to play. Thank you, Kylie.
Thank you, Sonia. And thank you everyone for attending this evening. So I'm Kylie Turton. I'm an APA sports and exercise physiotherapist and second year registrar in the specialisation program and a tutor on the sports medicine team. I'm going to speak tonight about clinical reasoning and the return to play process. So we need to consider that clinical reasoning and return to play go beyond the biological basis of injury, and it's a complex and multifactorial decision. It requires athlete-centred, evidence-informed and defensible consensus from our sports medicine team. And furthermore, we need to consider return to play, return to participation and return to performance. The diagram here on your screen on the right-hand side shows Sackett's evidence-based practice Venn diagram, which many of us will be familiar with. In this sense, we're looking at a pictorial representation of return to play. This needs to be informed by the clinician and their assessment, by the objective testing or the evidence that we gather from our athlete, and then also by the athlete, their sport, their symptoms, their views, and their expectations. In terms of athlete-centred management, we need to take the model of evidence-based practice and apply it to the athlete, as is shown beautifully in this diagram created actually by Sonia in our modern athlete subject. And in this diagram, we're looking here to facilitate ownership of the rehab process and an understanding of the biopsychosocial factors involved in return to play. So we need to consider the athlete's sport, we need to consider their mental skills, their coping strategies, their well-being and attitudes and beliefs to recovery. We're also putting this alongside their physical conditioning, goals, their technical skills, and also lifestyle factors that can influence recovery. As the sports medicine team, we then want to develop a partnership with trust and engagement to support the team to facilitate a return to play for our athlete and support the decisions. And to illustrate the case of a clinically reasoned return to play, I'm going to introduce Mia. So we're going to talk through Mia's case and a framework around a clinically reasoned return to play. So Mia is a 15-year-old gymnast with bilateral stress fractures at L5 and a stress fracture at L4 with significant edema, which was identified over 6 months ago. After 6 months of rehab and modified training, an objective assessment has revealed that all her symptoms are actually stable. However, she continues to report low-level pain, which is actually not related or has a minimal relationship to her activity levels. Repeat MRI and serial CT scans are clear and have showed that Mia has a medical clearance to return to play. She has had 3 months of relative rest and 3 months of a graded return to participation program. A decision now needs to be made in regard to Mia's care. Is she ready to progress her return to play? Artem, Bazzini and Barr in 2016 proposed 5 key questions to assist with this complex decision. Firstly, how does the clinician determine when the athlete is actually ready to return to play? Is physical recovery alone enough for a return to play? What does a successful return to play actually look like? What are the responsibilities within the team and to the athlete? And lastly, actually, should the athlete return to play? The decision remains one that's optimally shared between the athlete and the sports medicine team. And these questions all actually relate to Schreier's START framework. We're going to explore the START framework now in relation to Mia's case. So the START framework, or the Strategic Assessment of Risk and Risk Tolerance, was published by Schreier in 2015. This model provides a clinically reasoned approach to return to play. The model captures and discusses the key biopsychosocial elements of return to play without actually solidifying the answer. So it provides a clinically reasoned approach along a stepwise path. So firstly, step 1 and 2 are a risk analysis process or risk assessment. Firstly, step 1, we're looking at the assessment of tissue health. Secondly, the assessment of the activity risk or the tissue stresses that we're placing on our athlete in returning them to play. And thirdly, looking at the assessment of risk tolerance or the modifiers that we have that we're able to utilise. So in our first step of the framework, step 1, with the assessment of health risk, we're considering Mia and the patient demographics of her. So she's a 15-year-old female adolescent athlete who's skeletally immature. We need to consider that she is not a mini adult. And we also need to consider in this situation that Mia may have involvement of potentially REDS with a bone stress injury in this age group, which is a high risk in the gymnastics sporting arena. From a symptom perspective, Mia has persistent pain, which appears to be unrelated to her activity, and we consider whether there's central drivers here or the presence of nocipathic pain, as noted by Hanlon and colleagues in their 2017 commentary on pain in elite athletes. From a history perspective, Mia has had an injury history, including OCD in her right elbow and a left radial wrist stress injury. Interestingly, it was questioned as to whether she may have a genetic cartilage or collagen issue, leading to an increased risk of these bone stress injuries. A biopsy was taken of her elbow during surgery, however, this did not show any abnormality. If we're furthermore looking at the tissue health and the signs from Mia's physical examination perspective, you can see here on the slide that she really didn't have any physical examination findings to show that her pain was changed compared to at rest with provocative testing. And similarly, pain with function versus activity was unchanged after training, and her serial scanning, as we've discussed prior, was stable with no bony stress evident. Moving to step 2 on the assessment of her risk activity, certainly we need to consider that gymnastics is a high-impact, complex sport. It involves diverse movement patterns and repetitive extension loading. The high injury risk was highlighted by Sweeney and colleagues in a systematic review in 2018 looking at return to sport in gymnastics. Overuse and traumatic injuries in gymnastics were actually identified among the highest of any athletic sport per exposure hours. So there was 1.3 to 9.22 injuries per 1,000 hours. If we consider this as approximately equivalent to 1 year training of an elite athletic program. Looking at the sport and the position played is considered in this framework. So from Mia's perspective, she's an international junior level gymnast and competes on 4 apparatus. She has very specific skills required and a training load which consists of 5 days a week, 8 to 9 sessions per week, with approximately 28 hours in the week of training. We need to consider in this framework her limb dominance and also competitive level. And the limb dominance from a gymnastics perspective is more around her takeoff and landing mechanics, and particularly also her twisting direction, and they were all considered in this space. The ability to protect Mia from injury was looking at more so the management of specific skills and repetitions that we were able to control in her return. So bridging and static stretching into extension were removed from her program, as were aerials, which were skills that were increased in their extension demands and considered to be higher risk. Mia then limited the numbers of her high repetition, high impact landings, and we looked at specific choreography to decrease her extension bias skill elements in her routines. Protection of the adolescent athlete was also considered, with knowledge that in the culture of gymnastics, it has been one previously to train through pain and not report injury, unfortunately. This is changing, and it's currently driven by the media attention from the airing of Athlete A, which I'm sure many of us listening tonight would be aware of. Lastly, we need to look at the assessment of Mia's psychological readiness to return in her assessment of activity risk. Jackie's going to talk about this later, so just touching on it briefly, Mia did have some anxiety around returning to sport and re-injury, and some anxiety around the training time she'd missed and the potential loss of progressive skill development. and these have been identified previously as factors that are potential barriers to have a successful return to sport. The last step in the framework here is looking at the decision modifiers. So looking at this framework, the timing and season was perhaps not a factor as strongly relevant to Mia's role. However, it may be a decision, particularly if you're looking at athletes such as Sonia's case, whereby a gold medal is on the line. And that decision to compete may be very different compared to the first game of the season or the first jump of the season. Mia, in this case, had a strong desire to compete. So there was some pressure, I guess you could say, from the athlete to return whilst respecting medical guidance. Competition for her was a part of her identity of self. Her training group was also a big part of her friendship group and her network. And there were significant implications in this case around the psychological impacts of potentially leaving a sport, really not of her own choice. It is worth mentioning that the complex external pressure sometimes present for teenage athletes was not present in this case. However, certainly I have seen many cases where parents are actually vicariously trying to live their athletic dreams via their children and pressuring their children into a sport that they do not want. And I think it really needs to be said, we need to consider this. From a masking the injury perspective on the framework, in this case, effective pain management actually required education and effective education to Mia that tissue damage and pain were perhaps actually not equated in this case, given the credible evidence we had that there was no active bone stress on her imaging. Audiovisual resources were actually used to assist with this message, and some of us may be familiar with clips such as Tame the Beast, and there's an excellent clip on YouTube called Knowing Your Pain and What to Do About It in 10 minutes, which is actually appropriate for this age group and was used in this case. The conflict of interest and fear of litigation were not relevant in this case, the bottom two factors in the assessment of risk tolerance. However, as Nino will actually speak to, this is something to consider in a professional sport situation. So in actually bringing the framework together and making a decision regarding return to play, we need to balance looking at the tissue health, the tissue stresses, and the risk tolerance modifiers as have been presented. The START framework supports return to play when the risk assessment is below the acceptable risk tolerance threshold. In considering Mia's case, this brings us to our decision. Should Mia return to play? Yes or no? In Mia's case, there is no biological tissue injury evident. She has stable symptoms and has returned to participation without further pain. It is noted that she's an adolescent female and she's returning to a high-risk sport. Mia is well supported by her coaches, her medical staff, and her family, and she's got a very strong desire to train and compete and is able to be carefully monitored in the gym with her load managed in a very structured way. A collaborative decision was made to support her return to play towards her performance goals. This case has been designed to display the complex interaction of the many factors in a return to play decision, with reference to the START framework. The clinically reasoned approach goes beyond the biological basis of injury and is complex and multifactorial, as has hopefully been shown. We want to make then a defensible decision related to the framework. And this requires an athlete-centered approach, evidence-informed and defendable in our consensus. Hopefully this example has assisted in providing a framework to consider and further explore clinically reasoned return to play decisions with your athletes. Thank you.
Thanks very much, Kylie. I think that really is a great case example illustrating the interplay of all these contributing factors and also illustrating the complexities of it. And also just the way you've included how we can consider these within the START model, which includes the tissue health and the stresses and also the risk tolerance modifiers. And I think very clearly this is evidence-informed and not recipe-driven. The next speaker I'll introduce is Nino, and he'll explain some of the key evidence and the criteria that are important in returning to play following acute hamstring injuries. And I think we want to keep in mind that this also is not a recipe. even with a similar injury, no one athlete's likely to present with the same profile. But still, these are really important targets and goals to work towards. So thank you, Nino, and welcome.
Thank you, Sonia, and thank you, Kylie, and welcome to you all, alumni and students of the Melbourne School of Health Science and clinical partners. My name's Nino Lascala, and I'm an academic tutor at the Masters of Sports Medicine program. And tonight I'd like to cover issues surrounding return to sport after a hamstring injury. So as most of you are aware or have been involved in the process of rehabilitating an athlete back to sport, one of the first questions that is commonly asked is, how long before I can play? This most often is a query from the athlete, or perhaps it's the anxious coach missing his star player, or a concerned family member or teammate, and perhaps it's information that's relevant to a wider audience and fan base. So as health professionals, how do we make a prediction? Is it based on your previous experience dealing with hamstring injuries? Do we approach it via an evidence-based clinical reasoning framework, or is it simply a guess? So issues that surround a successful return to sport after hamstring injuries are its high rate of recurrences. It was found that in European footballers, 13% of hamstring injuries reoccurred within the first 2 months of returning to sport. In AFL footballers, 30% have been found to reoccur over the course of the first year. And we know that recurrent injuries require greater rehabilitation time and time to return. The two most notable risk factors surrounding hamstring injuries which must be considered are age, with an increased risk in older athletes, and previous hamstring injury. Strength, high-speed running loads in the preceding weeks and other previous injuries are also of lesser risk. There are certain key measures which may give an indication of the prognosis, such as pain greater than 6 on a visual analog scale and pain with daily activity for more than 3 days, popping sensation at the time of injury, bruising, a difference in passive straight leg raise, were all associated with 40 days to return to play. Time to walk pain-free, the location of maximal tenderness, the type of injury are all also associated with longer rehab times. But can these be used to determine when a player is ready to return to play? In order to implement a process, it's important to define what return to play is, what are its surrounding criteria, and who should make the return to play decisions. In 2016, a consensus statement was presented that included a continuum of 3 elements that were based around a criteria-based progression. And as a minimum, information was required to define the sport and the level of participation the athlete aimed to return to. So the 3 elements were return to participation, which may be that the athlete is in rehabilitation or is in training, either modified or unrestricted, or is returned to sport, but at a lower level than the return to sport goal. The second, return to sport, this is where the athlete's returned to his sport, but not at the desired performance level. And finally, return to performance, in which the athlete has returned to sport and is performing at or above his pre-injury level. So what does it mean to return to sport? Well, depending on who you are, it may mean many things. The athlete may wish to return to training and be amongst his teammates at any cost. The coach may want him to be at full fitness and performance, and the medical staff may require the athlete to be performing at a safe level with little risk of re-injury. Schreier in 2014 found that there was a general agreement that medical doctors, physios and athletic trainers were the best to able to synthesize medical factors relating to injury risk and complications from injury. But there are a number of return to play decision modifiers, as Kylie's described in step 3 of the START framework, which are not medically related. For example, financial interests, the timing of the season, and internal pressures, all of which are best made by athletes, coaches, and the sports associations. Therefore, a shared decision across multiple stakeholders with different views should be had. Van der Horst undertook a systematic review in 2016 that looked at the definitions and criteria surrounding return to play decisions in hamstring injuries. He found that there were many definitions around return to sport, ranging from the athlete's self-reported readiness, clearance being made by the medical staff, ready to return to full activity, ready to return to full team training, is available for match selection, or is at simply pre-injury level. So there appeared to be no consensus or definition surrounding return to play of hamstring injuries, nor standardisation of clear criteria in the decision making. Many definitions circulated in the literature. Then this study was subsequently followed up by a Delphi study the following year in 2017, and 50 experts in the field of hamstring injury management were selected by FIFA Medical Centres of Excellence worldwide. Their definition of return to play was the moment a player has received a criteria-based medical clearance and is mentally ready for availability for match and or full training. So further to this, they looked at a criteria around 6 key parameters, that mainly being the absence of pain, similar strength, similar flexibility, functional performance, medical staff clearance, and other, such as imaging, correcting dysfunction, and a theoretical period of tissue healing. So the experts reached a consensus on the following criteria. The absence of localised pain on palpation was supported by a study by DeVos in 2014 that found that hamstring re-injuries were four times more likely to reoccur if there was pain on palpation. The group also felt that there should not be any pain present when testing flexibility, strength, and functional performance. They agreed that flexibility could fall within 10% of the other limb or a baseline measure. They also felt that psychological readiness and confidence was important, as too was field performance tests such as repeated sprint abilities, deceleration running drills, single leg bridge strength tests, and position-specific GPS data to target match-specific rehab. Interestingly, there was no consensus on either the inclusion or the exclusion of similar eccentric strength tests. One group felt that the eccentric mode of contraction is a phase in which injury occurs and that achieving similar strength can reduce the injury or the risk of injury, whereas the other group felt that strength tests aren't functional, asymmetries are normal, and there are many factors which influence the reliability of measuring strength. However, there was a consensus on certain contraction types that should not be included, and these were hamstring and quads peak torque and their respective hamstring quad ratios, as these were deemed by the experts not to be associated with increased risk of injury. And this was supported by Fosekis in 2011 that found that athletes who had returned to sport, only 11% had strength symmetries. Furthermore, Toll in 2014 reported 67% of all football players that clinically recovered from a hamstring injury had at least one hamstring isokinetic testing deficit of more than 10%. Strength and flexibility changes over time, and they're influenced by exposures such as fatigue. It may be more appropriate to monitor strength throughout the season rather than a baseline strength screening measure at the commencement. Although neuromuscular function is important, the experts decided to exclude this due to specifying the concept, and the assessment would go beyond the scope of that Delphi study. And recent studies have reported that changes on MRI continue well after clinical hamstring healing, and that baseline MRI findings aren't predictive of injury. Competition of full training and match were excluded, as these were included in the definitions of return to play. Interestingly, at a similar time, another Delphi study was being investigated. This included the physiotherapists and doctors of 20 professional English football teams. They also had similar criteria surrounding the return to play. But they emphasised functional performance, especially repeated sprints, which contributes to a player's aerobic and anaerobic physical condition, as fatigue may contribute to injury. Sprinting was also placed the eccentric load through the hamstring, which is considered vital. Also gradually increasing the player's workload, which reduces the spikes encountered, which may contribute to re-injury. They both felt achieving similar flexibility, both active and passively was important, and also the absence of pain. Although the author of this paper discussed the issues surrounding testing contraction modes and asymmetries, all participants of this Delphi study felt that full strength must be achieved, and all agreed players' confidence was important. So these practices adopted worldwide. Dunlop in 2019 undertook an online survey of 130 professional Premier League soccer clubs to determine if Premier League football teams worldwide followed a return to play continuum, to identify if return to play criteria was used, and to understand how return to play decision making occurs in practice. So they found that they all followed a return to play criteria, with 100% following both a return to run and return to train criteria. 27% cited challenges, most notably from management and coaches, especially when considering return to play phase. This may influence why only 95% followed a return to play criteria, and only 79% decided to follow a return to performance. Possibly it was felt that once the player returned to play, that was also when an athlete had returned to performance. And 80% used a shared decision-making approach with at least 2 people involved. So in the return to run phase, the most common criteria monitored was the absence of pain, as stated previously, no pain on palpation, stretch, strength, and functional performance, and also strength measures were monitored. Interestingly, it was suggested that the presence of pain increases the risk of re-injury, but also may unnecessarily prolong rehabilitation. In the return to train phase, training loads, hamstring strength are monitored, and it's important to identify that although the players return to team training, additional training may be required, as achieving maximal loads may only occur after a player has returned to games, which can often be 2 within a week. And then in the return to play phase, training loads continue to be monitored, especially on field, achieving GPS benchmarks based on either the player or position-specific match metrics, such as maximum speed, high-speed running distance, and sprint numbers, which are all important to ensuring readiness to return to play. And then when considering return to performance, little is known about the association of training loads to performance, and maybe metrics related to physical and technical, tactical and cognitive qualities are more likely to be important. So in summary, although not all hamstring injuries are the same, nor are the athletes who possess them, or the varied sports which demand and test them, implementing a criteria-based progression and including multiple stakeholders in decision-making within an athlete-centred framework will ensure that the best outcomes when returning to sport.
Thanks very much, Nino. I agree, no one athlete's the same. And that's a really great slide to finish on, because we know that particularly with hamstring injuries, that the injury patterns are different in soccer compared with, say, athletics. So it's not even just the athlete, it's this end game that we want to consider and what we're returning our athletes to. Before I introduce our next speaker, I'd like to just remind everybody that the Q&A thread is there. If you have any questions for our speakers, please put them in there. So our decision to return to play, of course, is only as good as the evidence that we base it on. And that being from the information that we gather in our athlete assessment and also from our understanding of the injury and the related research. And so on that note, I would like to introduce our next speaker, Cade Patterson. Thank you, Cade.
Thank you, Sonia, and thanks very much for the opportunity to talk, and thank you to everyone out there joining us tonight. Sonia said, my name's Cade Patterson. I'm a certified sports podiatrist and a senior research fellow here at the Centre for Health, Exercise and Sports Medicine in the Department of Physiotherapy, and I'm an academic tutor as well in the sports medicine program. So in contrast to a little bit of what we've heard tonight, there's actually relatively little information on return to play for lateral ankle injuries. And I think this is at least partly because the perception that they're relatively benign injuries and the so-called simple injuries. So my agenda tonight really, I guess, is to outline the scope of the problem and hopefully impress on you a little bit that these injuries and their longer term consequences can in fact be quite serious. And then towards the end, I'll touch on what we do know about some of the return to play criteria. So to start, I think we should start on the same page. So we'll look at some of the definitions of what is a lateral ankle sprain and what is a chronic ankle instability. So with lateral ankle sprains, the definition really shows us that they're acute injuries, they're traumatic injuries to the lateral ligament complex, and typically as a result of excessive inversion of the rear foot or plantar flexion and adduction of the foot. And then this, of course, results in some deficits of function and disability. Whereas when we look at chronic ankle instability, there are 3 criteria. So there's at least one lateral ankle sprain, and the most recent of those had to be at least 3 months before that particular time point, as well as sort of inflammatory symptoms like pain and swelling and some interruption to physical activity that were at least a day. The second criteria is that there is some giving way, at least 2 episodes of giving way in the last 6 months, and that's your typical unpredicted episode of inversion, but that doesn't result in a sprain, and or some form of self-reported instability. And I've given 2 examples here in brackets. So that's the self-reported objective measure of the Cumberland ankle instability tool, as well as the identification of functional ankle instability survey there as well. And then the third and final criteria is some sort of description of disability. And again, there are a couple of examples we can use. So the ones that I've picked out there are foot and ankle ability measure or the foot and ankle outcome score. So how common are lateral ankle sprains? Well, perhaps surprisingly, they're actually the most common injury that we see. They represent about 15% of all injuries in Australia. We see in Australia, that nearly half of all adults report having experienced a lateral ankle sprain. We also see particular populations are more prone. In particular, females are more prone than males. And just in case you're not familiar with the metric there, so that's 13.6 injuries per 1,000 athlete exposures, where an athlete exposure is 1 athlete with 1 game or training session. So that would be 1. So it could be for 1,000 athlete exposures, it could be 2 athletes with 500 games or training sessions. We also see children are actually much more prone to this injury than adolescents. So just under 3 athlete exposures versus just under 2. And adolescents in turn are more prone than adults. So adults we see at 0.7 athlete exposures. And then we also see certain sports are more predisposed to this injury as well. And in particular, most commonly we see these injuries in indoor and or court-based sports at 7 athlete exposures. So that sort of brings me to some work that we're doing at our group here at the Centre for Health, Exercise and Sports Medicine, and in particular our master's student, Patrick Rowe. Patrick's also the team physio and strength and conditioning coach for the Melbourne Uni Lightning squad, which is in the Vic netball league. So I'll highlight some of his work on netball as I go through tonight, just given netball obviously has a high proportion of children and adolescents, is predominantly female, and is also, of course, a court-based sport. So it really ticks all of those main risk factor boxes. So where we saw before the population average in Australia is about 50%, we can see in netball it's around 80%. So much, much higher. And then moving into chronic ankle instability. So how common is chronic ankle instability? Well, actually, we don't really know the prevalence, but what we do know is that of all people that experience a lateral ankle sprain, around 80% will go on to experience another sprain and instability. And around a quarter of the population actually have a chronic ankle disorder in Australia. And then if we move into netball, we can see that that prevalence rate actually rises from a quarter of the population up to 50% of athletes in netball report a recurrent sprain. And of those in particular, more than half are going to go on to experience some sort of self-reported moderate to severe instability. So we've seen the scope of the problem, and hopefully I've showed you that it is a very common problem, but what are the associated factors that we do see? So we certainly see persistent symptoms of pain and instability, and these are persistent, ongoing instability. We see people with chronic ankle instability have significantly lower self-reported disability, and this is using a reliable and valid measure called the short form 36 tool. And that's compared to the general population. But of course, I think most of us would know that one of the major consequences of lateral ankle sprains and chronic ankle instability is ankle osteoarthritis. And in fact, about 80% of all ankle OA is post-traumatic due to a sprain or chronic instability. And I think of what's really concerning is that on average, the ones that have experienced ankle OA due to trauma, they're getting the OA at least 10 years earlier than those who have primary ankle OA due to non-traumatic causes. So they're getting it at a much younger age. So that's the size of the problem. When we look at return to play, there are a couple of flags here as well. I think, 50% of people aren't seeking treatment for their lateral ankle sprains. We really see about 70% of people are returning to play within 3 days and 85% within a week, and that's regardless of whether it's their first sprain or a recurrent injury. And in particular, I think this is crucial because we can't actually assess the integrity of the lateral ligaments for at least 4 to 5 days. So manual stress testing of those ligaments are actually unreliable during that period because of the swelling and the pain from the injury. But if we delay the testing for about 4 or 5 days, the accuracy of diagnosing a ligament rupture actually increases substantially. I think that the sensitivity is something like 95, 96%, the specificity of just under 90%, around 85%. If the ligament is injured, something as well that we have to consider in your return to sport plan is that the ligament healing times really tend to range from 6 and up to 12 weeks. So that's quite substantial, and that's something I'll touch on again when we do look at return to play guidelines. When we look at netball, so if we see 85% of people are returning to sport within a week in netball, 3/4 are returning immediately. So they're not taking any break at all. But of those that do rest, the vast majority really only miss a game or at maximum 2 games. So what are the guidelines on return to play? Well, there are none. So there are no guidelines specifically for lateral ankle sprains. In the research world that we all occupy, there are very few studies that report their return to play criteria. And look, as far as I'm aware, there very few sports have recommendations for return to play specifically following a lateral ankle injury, as opposed to things like hamstring and ACL injuries. So, as I mentioned earlier, this sort of led our master's student Patrick Rowe to do some research in this area, and the hope of developing some return to play guidelines following lateral ankle injuries. And this is the first step in his work, which is from a narrative review that we've written. And I've reproduced the infographic on his best practice guidelines that Patrick developed, and he's kindly allowed us to reproduce it here. And so my second last slide, which is coming up, will focus on this final box down here, which is the return to play criteria following an ankle sprain that we've developed. So when we look at those, we can see that there are 5 components that must be considered before clearing a player to return to play. So the first one of those is the use of reliable, valid, objective, self-reported questionnaires. So in this little box here, I've given some examples that we've suggested for instability, such as the Cumberland Ankle Instability Tool, for function, which is the foot and ankle ability measure, but importantly, I think consideration of the psychological readiness, and that's using a tool such as the injury psychological readiness to return to sport scale, which is rather wordy. And so Jackie, who's coming up next, she's going to round out the panel and we'll go into a little further detail on that psychological readiness. So second up, we see physical assessments. And so we recommend multimodal physical assessments that assess range of motion, so such as the weight-bearing lunge test, lower limb strength, and of course balance using something like a star excursion balance test, and then functional ability, particularly those relevant to the individual sport. And so these include functional tasks like running, jumping, landing, cutting, and so on that I've got down there. Thirdly, where possible, we recommend the individual should have completed a full injury prevention program that's endorsed by their sport, and one that includes some sport-specific movement patterns, if that is indeed possible. If you're not aware, some examples that I've got there again, netball specific. So there's the Netball Smart program in particular from Netball New Zealand, and I'd encourage you to have a look at that. It's a very good program. Fourthly, before returning, there should be a quantified graduated return to training that includes some restricted and then unrestricted match simulation, and then gradual introduction of match play in there, and talked a little bit about that as well. And then finally, we'd also recommend the use of external supports like taping or bracing, and that's particularly if it's within that time, that 12-week time frame that I mentioned earlier that it takes ligaments to heal. And so the literature really is unequivocal on the ability of these sports to help prevent secondary sprains and reduce self-perceived ankle instability, but also to increase movement confidence. And importantly with those, which is a common concern for patients and some clinicians, there's no deficits to long-term strength using these that's been shown. So look, in finishing up, my key messages are firstly that I hope you've realised lateral ankle sprains, chronic ankle instability are very common, and the populations we see are younger girls and in court-based sports. They have serious long-term consequences. Most athletes, unfortunately, return to play well before the ligaments can be accurately assessed by us, but also before that they've healed. And then finally, return to play should be objective using multi-dimensional criteria. So thank you very much.
Thanks very much, Cade. It's really clear how quality research underpins our understanding of injury. And I think also, particularly with these common injuries, it's important to keep critiquing our current practice, or in this case, what happens in the real world, compared to what the evidence suggests would give better outcomes for our athletes. So on that note, I would also like to introduce Jackie Lauder, who is our sports psychologist on the panel this evening. I think we've all mentioned the psychosocial influences of injury and rehab and return to play. And in focusing on the injuries and the injury science, we certainly don't want to lose sight that these aspects, of these aspects, including, whether an athlete or yourself, whether they're front and centre in your decision making, or how they fit within optimising your athlete's recovery and their performance and their well-being as a whole person. So welcome, Jackie, and thank you for being here this evening.
Sonia, so much for having me and giving me an opportunity. It's I work clinically for most of the week, and then I consult. I'm the team psychologist with Melbourne Storm, and then through the SSN and through some of the Olympic sports. So a little bit more practical, I guess, from my side, and psychology is often one of the areas that really gets missed in return to play. We get so much knowledge and understanding physically of what to do, and I think it's only in recent times we've really seen the psychological component get acknowledged. So from our end, we have a couple of things that we have to consider straight away. And one of those things is looking at what time of the season an athlete may be injured. If it's at the beginning, so they know straight away they're going to have time to come back. If it's at the end of a season, then that might be a little bit different in terms of their compliance. And we also have a look at, I guess, what point of their career that they're in as well. So if an athlete is at the very beginning of their career, or if this is going to be potentially their last season or their last opportunity, that can make a really big difference to psychologically how they manage themselves. We also look at how traumatic the injury was and the incident was, because that will give us some sort of idea of what we may have to deal with, and that the athlete may physically recover well before they psychologically recover as well. So one of the things that we have a look at is if an athlete has an injury that's going to keep them out for 4 to 6 weeks, anything within that or beyond that is where we would make sure that they come through and psychologically just have a chat to us and get assessed, so that we have a good understanding of where they are and we can make sure we support them through their rehab process. We also have a look if it's a repeat injury or a brand new injury, so they do know what's ahead of them if it's a repeat injury, or if they've got absolutely no idea, and if this is their first injury ever. So that'll play a part for us psychologically. And the other thing, as Kylie mentioned earlier as well, probably one of the biggest areas, and I'll go into it a little bit later, is athletic identity. So how much does this athlete actually identify as an athlete? Is it the biggest identity in their life, or is it very well balanced out with other areas of their life? And the other thing we have a look at, if it's an individual or a team sport. So if they're in a team sport, it will be, what is their role in the team? Are they one of the superstars and they're going to have a little bit more pressure to come back earlier, particularly if that team is looking at finals? If it's a rookie, then we give them a little bit more time. And if it's an individual, is this their financial income? Is that going to play a part in their psychological rehab, and how quickly they might comply, or the stress that might come with managing that injury? And then obviously the other side of it for us is looking at life outside. So how well balanced is this athlete? Are they studying as well? Do they have good family support? Do they have a job? Is this their profession? So we have a number of things that we would consider. So if we have a look at this initial diagram, I guess we're looking at overall the characteristics of that performer. So do they have a really good solid base of psychological skills? What motivates them? What sort of personality do they have? Because that will play a huge part in how they process it, but also how well we can deal with that person. Genetically, is there a part to play there? And then we also have a look at the avoidance of injuries. From the other end, we look at the characteristics of their social environment. So looking at the program, the geography, the support from within the sport as well as outside. And then we look at the characteristics of their training practice. So how good are they with recovery, the quality of their practice, diversity of all their different sports experiences. And then we look at obviously working in with a dietitian and their training loads and strength and conditioning as well. So as we move through and we have a look, I guess we follow, this is probably the main model that we would follow when we look at anyone psychologically recovering from an injury. So if you have a look at that pre-injury, the personality side, if we've got someone who is very good at coping, they're not someone who will over-dramatize things, or are they someone who's going to really underplay it because they don't like to cause hassle for everybody else, they don't want to stress everybody else, or they want to get back quicker and don't give us all of the information. So we have a look at what that personality is like and spend quite a bit of time on that. We look at how they perceive themselves, and that comes into that athletic identity, what motivates them, what their pain tolerance is like. So we had an athlete a number of years ago who actually did an ankle injury, was 24, had never had an injury in his life. When he went down, the pain appeared excruciating. 10 minutes later, he walked out with a bandage and not a very serious injury. But for him, that was his first injury. So that was his biggest level of pain he'd ever experienced. So we have to be mindful of where it fits in for somebody. We look at their coping skills. Are they someone who generally copes well? Are they going to need a lot of attention? Do they need to double check, triple check with the medical staff all the time as well? So quite high maintenance. We look at their history of their stresses and then what their mood states are. Other things we would consider is demographics. So we look at obviously the gender, the age of the athlete, so how much wear and tear on their body versus somebody who's just brand new in, if they've had injuries in this area or not. Ethnicity comes into it for us because it is determined in terms of whether they will comply with some sort of rehab processes and not others. So if we have certain females that might be Muslim or other ethnicities where they're not allowed to do their pool recoveries in a pool where there's male athletes. So we have to consider a lot of those things as well. Having a look at their socioeconomic status. So how much are they going to be able to afford the gold standard rehab versus how much are they going to have to do on their own, and what sort of access they have to equipment. And then we look at their prior sporting experience. So they may never have had a good model of sports medicine around them. They've always done things themselves, particularly if they've now gone up to higher levels of sport. So they may have greater support networks now. And then we look at their physical side, so their use of ergogenic aids, their physical status. The other thing we would consider here is their eating habits, working in with a dietitian, because a lot of athletes psychologically will think if I'm not participating at the moment, they'll change their food intake, and that can cause us other problems. So we just have a look at, does that change through injury? When we start to look at their overall stress response to the injury, we break this down into 3 areas. So their cognitive appraisal, their emotional response, and then that behaviour response. So can they adjust their goals cognitively and recognise, okay, I've got to put everything back 4 weeks, or I'm not going to achieve that this season? Their rate of perceived recovery. So we listen very carefully when they first got injured, what their dialogue is like. So straight away, you know, they're saying how long, how long, how long. There's a real sense of urgency. If they feel like, oh, this is the end, and it's quite dramatic. So listening very quickly to how the athlete's initial reaction is gives me a bit of guidance as to where we might start with them. Their belief about whether they're going to be able to get through this, their sense of loss or relief. Sometimes for an athlete, an injury can come when they're feeling high amounts of pressure. And so whilst we all think it might be a drama for that athlete, it may actually be a real relief to have a little bit of breathing space. Then the other things we look at is from an emotional response, that fear of the unknown. What happens next? If they've never had to have surgery before, what comes with that psychologically? Is it going to change their moods? Obviously, as athletes, you know, they're producing all the great chemicals that we want them to when they're exercising, but if they're now not able to exercise and they have a history of depression or any mental health issues, is that going to make that more prominent for them? The frustration and the boredom, athletes are not always the greatest patients because they want to be out there and they want to be doing it. And it's amazing how many athletes become 10 times better when they're on the armchair and criticising whoever's playing in their position. So we have to think about those things as well. Are they having quite a positive attitude, or is there a real grieving process going on for them? And then when we look at the behaviour responses, how well are they adhering to rehab? Do we have a history where they've tried to cut corners or tell us they've done stuff, or are they very, very diligent and we know that we can trust them to do things? Do they have some psychological skills and strategies in place? Use of their social support networks, their risk-taking, effort and intensity, and just generally their behavioural coping. And then the other factors we look at is just how well resourced they are and some of the interventions. So socially, making sure we keep them in line with their teammates, attending team meetings, or still working in having regular contact if it's an individual sport with their coaches, so they still feel part of the network and part of the system, even though they may not be on the field, on the court, in the pool. So moving on from this, what we have a look at is that psychosocial model that I think Kylie brought up a little bit earlier. So some of the things that I've just been through, those cognitions, the affect, their behaviour and their outcomes, so it's just presented in a little bit of a different way, but crossing the same things. I guess the thing we would also want to just have a look at there is on that behaviour side is, are we seeing any increase in substance abuse? Do we need to be aware of that? Any suicidal ideations or, I guess, indications that we may have to keep a closer eye on this person? So then we'll have a look at moving beyond the model to, I guess, their confidence in returning to sport. And the big part of that is just simply having a conversation with them and listening for the cues, whether that be the constant asking of the same question to the physios or the doctors or the podiatrists or whoever's involved. And with their psychological readiness, we're looking at their previous performance standards and then realistic expectations. As we know, every athlete, they're all drama queens. It's either really good or it's really bad. So we want to know, I guess, have they got a realistic adjustment of coming back into sport and saying this is going to take a couple of weeks to get back to where you were before, or whether that is, if it's been more of a minor injury, then we can get them back to those performance standards. But just helping them reset their goals is really important because they may not have that ability to do that themselves. So again, moving through, when we start to look at, I guess, strategies for our athletes, one of the things that we will have a look at is giving them some goal setting. So how do we do that? Where are we? What's our starting point? And making sure that as a psychologist, we're working in very closely with knowing what has been the instruction from the doctors, the physios, the strength and conditioning staff, so that we don't overdo those. Then we would use something which I guess a lot of people hear about is imagery. So getting them to be able to see and feel the sport without necessarily getting on the court or the field or in their particular arena. So when we're looking at those sort of things, it takes a little bit of time to develop them, but we can see some really amazing results before we put somebody back into the field of play. At the moment, one of probably the more recent strategies and tools that we have available to us is using a lot of virtual reality programs. So putting some of the virtual reality spaces in front of the athlete allows them with that decision making, their timing, which nothing will replace being back on the field. But if we can start to help with some of the pace of some of those things and getting them into those mental headspaces, it can make a real difference for us. And then the other one is looking at their self-talk. So the slide you're seeing at the moment refers back to that athletic identity that we talked about, which for me is probably one of the biggest areas when we're looking at that psychological rehab. So we have a look at an athletic identity questionnaire, and it has a few questions like some of the ones I've put up. So I consider myself an athlete. We look at how strongly that person would say that. And if they have other areas of their life, can we fill some of their time with that? Or if this is the only thing they relate to and this is how they define themselves. Looking at their goals, where their friendship networks are most of them in sport, or do they have them across other areas of their life? And if it's the most important, spend more time thinking about sport than anything else. Participating in sport makes them feel good, so we have a look at where their moods and their sense of self comes from, how others see them, and then how they're judging themselves. So I feel bad about myself when I don't do so well in sport. So we just make sure we go through these questionnaires, not so much necessarily to give them a particular mark, but just see roughly how they respond to those. And then one of the other questionnaires we will start to have a look at after we've done the athletic identity is we can go on to their readiness to return to sport. So having a look at where they've got a lot of confidence, no confidence, sitting in the middle. So their return to play, managing their pain. We work a lot with some of the language that Cade was talking about before in terms of if they're in pain, are they in discomfort? Is it just a bit sore? So really trying to make sure that we don't look at pain as the worst and the only option. I think discomfort is sometimes a better word, or just a little bit of soreness, because they're going to get that when they go back to training if they haven't used their body. Finding out their overall confidence, and then can they go back and return to sport? How much time are they spending focusing on that injury? And then looking at their confidence and their skill level and their ability. So there's some of the main things that we look at from a psychological perspective, and then we would, like I said, work with the athlete on some of those strategies and make sure we work in with the sports med team the whole way through. Thanks, Sonia.
Thanks very much, Jackie. And as we've heard from all our speakers this evening, those psychological readiness for return to play is just so integral to successful injury rehab and to wellbeing, and even just to people's relationship with sport and exercise. So thank you for explaining for us what some of those psychological aspects are more fully and how we can think about them. And I also love the way that you referred to them as skills. So that to me sounds like things that we can learn and that we can change and that we can get better at as well. So as a non-psychologist, another thing I've learned from Jackie is that just with a greater understanding of what these models are, or using some of these questions perhaps as conversation starters, we can really seek to understand our athletes and our patients better as well, where they're at within themselves and what's most important to them. And that helps us a really lot in all our types of management and working with people as health professionals. So just before we return to the panel for some questions, I'd just like to re-emphasise some of the common key points that our speakers have shared with us this evening, so that you can take away these and think about in your own practice. So evidence-informed and defensible return to play decisions are integral to our sports medicine practice. That's on the field of play, in injury rehabilitation, and also with regards to policy, process and guidelines. And these, of course, are led by the nature of the athlete's injury, the tissue health, the stresses, but they need to be with the athlete's needs at the centre. And what we're going to propose as the optimal way to manage this interplay is that between the risk tolerance and mitigation is with that shared interprofessional model. So I'll leave you with these thoughts or these calls to action tonight. So build your readiness for the chaos through analysis of and the stepwise preparation for our end game. Follow objective multidimensional criteria and recognise when the readiness stages of these multidimensional criteria don't align. Really seek to understand the characteristics of the athlete and their environment. And of course, for ourselves, evolve our practice according to new situations and new evidence. So throughout this evening, our audience and Scott Wilson have been busy on the Q&A thread. So as we come back together, Scott, I'll ask you to direct some questions to the panel, please.
Thanks very much, Sonia. My first question, if I can, is for Cade. And can I start just by thanking all of you for great presentations? I certainly took a lot away from it. Cade, one of the questions that we've had come through is regarding your thoughts on the literature on frictionless tape for the lateral sole of shoes for preventing lateral ankle sprain.
What are my thoughts on it? Yeah, I've seen, it's quite an interesting paper actually. They've given it the name Sprayno, which is a very attractive name for some tape that you stick on the bottom of your shoe. Look, the evidence from what I can tell is really good. So it was a really large study published in British Journal of Sports Medicine. It was as they said, the questioner said, it was a frictionless tape that sticks to the bottom and the side of the shoe. It was a large study. I think they tested over 500 people. Out of those, I think 1 in 5 had a non-contact ankle sprain. And the injury risk reduction in the people with the tape was around about 20% for all lateral ankle sprains. But then when they looked at serious ankle sprains, it was something like 50% injury risk reduction. That's quite substantial, and I think they also had a reduction in games missed in those that had the tape. Something like they missed 1 game versus 2, or I can't remember that figure exactly. So, yeah, look, I think it's certainly something that we'll probably start to see. I suspect it'll be incorporated into footwear pretty quickly.
Thank you very much, Cade. Jackie, if I could throw over to you, and thank you again for a fantastic presentation. One of the attendees has asked what tool is most used to determine psychological readiness to return to play. What would you say to that question?
Conversation, to be honest. It's the number one tool that we use. We don't use, like I said, those questionnaires for us are a little bit more of a guidance for the actual questions to have, but having a conversation is what's going to give you the biggest gauge. And I think that comes down to also making sure that through the rehab process, we really develop a relationship with a person and not just speak to the injury. Because I think when you're doing that, you're going to get a lot more of an accurate response from that person. So whilst there's lots of questionnaires, conversations are our number one tool in building that relationship with them.
I think that's such a great comment, Jackie, where in the world of evidence-based medicine, we use questionnaires and outcome measures to help guide our practice. But to hear you comment that way, it's such a great reminder that knowing your athlete, having that conversation, unpacking it, is still such a great pillar to come back to. It's fantastic. Sonia, if I can ask you, and we can go back to your COVID-safe first aid kits. I think that's a really great example of being nimble in a changing environment. I'm really interested if you could please talk to the audience about your process. How did you arrive at developing those COVID-safe kits? Were there resources and materials you could use, or did you have to, use some good clinical reasoning?
Yeah, thanks, Scott, and thank you to the person that's asked that question, because it was a lot of time and effort to get our footy club ready for a COVID-safe season. And I think the first thing that I did is in line with what our speakers have said here is look at what we wanted to get to. We wanted the kids back playing footy if we could. As soon as we were allowed to, we wanted the kids back. And we need to then look at our kit and say, well, okay, what part of this kit is compliant? What can be wiped and what can't be? And so the first hurdle you hit is the actual bag. I mean, there's no way of wiping. The protocols that were in place were hand washing and wiping footballs and sanitising balls. And then the medical kit itself is made of cloth. So that was the first obvious thing that needed changing. And so we switched all those over to tackle boxes. The other thing, again, for me, the crucial items on the side of the field of play is the kit and then the box of ice. And so at a junior footy club, we used cloth. What we had in place was cloth lunchbox type cooler bags and reusable ice packs. And so those needed to go as well. So we had very quickly priced small eskies, and the person who's on duty brings ice from their freezer or stops at the petrol station on the way. So those were the two things that we changed. And I'm going to say that we did that for under $500. So $500 is quite a lot for, many footy clubs and many sports clubs. But in terms of changing what we had in place in a short space of time to something that was going to, feel really good, that we can go ahead here because we've got this, we can be compliant. That was really important. So that was one of the big changes, the bags of ice and the single-use nature of everything. And particularly in budget-conscious clubs, I'm not making a comment about cleanliness, but we do try and be efficient and economical with everything that we use. And in this situation, we had to be, number one priority was being compliant, because otherwise the club would be told we had to stop and fined a lot of money. But also just being safe for everyone, a junior footy club. And and parents dropping their children off in our care. You know, we really do have a responsibility to provide that safe environment for them. I don't want to steal too much airtime, but one of the other issues we came across was actually qualifying our trainers and re-qualifying for the season. This pandemic restrictions came in March, and everyone needs to have, as you will know, a yearly CPR update and first aid certificates, if not the trainer qualification that needs renewing every 3 years. So we also had to do that in small groups with physical distancing and online components. So there was quite a lot to work through. But in answer to the question, how do we do it? We decided very clearly what we wanted to do to see if we could make it happen. And then we worked back from that and put the steps in place to say, okay, well then to make it happen, these are the things we need to change. How much is that going to cost, and how quickly can we get it in place? And that's what we came up with in our club.
Thank you, Sonia. And it's a great example where, you know, it doesn't have to be a huge cost. You know, most people work in community sport and won't have that big budget to make those changes. Thanks for sharing. Nina, if I can come across to you, I loved your topic. It's something that's close to my heart, and it really highlights that we haven't really collectively become much better at managing hamstring injuries over a long period of time. One of the questions we've had to you is, do you have any clinical commentary on allowing pain with hamstring rehabilitation, both in rehab and running, with respect to the type of muscle injury, that is myofascial versus central tendons? There's a couple of questions in there for you, Nino, but if I could put that to you from the audience, that'd be awesome.
Yeah, thanks, Scott. I guess when we're talking about rehabilitation and return to sport, they're probably, you know, very intimately related. And we know that when we commence rehab earlier on, rather than waiting for pain to completely go away, we tend to get better outcomes. So we're probably a little bit more tolerant of a low level of pain when we're performing exercise or when we're starting to do, you know, measures in rehab. When it comes to return to sport, a lot of the discussion, you know, in those papers, those expert papers, talked about no pain with palpation, no pain with stretch and strength and clinical measures, and then you know, on field with functional performance and running. But I guess you need to consider when returning back to play all the factors, and in an ideal world, as Sonia alluded to, you would like to have 100% clearance in all those criteria and all those domains, but you know, you may not. And if a player is performing well and has you know, good clinical measures and he's confident, you know, do you allow him to you know, return to play? And I guess that needs to be a shared decision between everyone. But again, if as Sonia said, if you feel like you're needing to spot the athlete and you're quite anxious and concerned of them being out there, they're probably not ready to be out there. So you know, when it comes to rehab, back to the question, when it comes to rehab, you know, I'm tolerant of low level of pain. Probably more so if it's you know, a central tendon or tendon kind of pathology. And when it's returned to sport, you need to consider it with, you know, with many other factors as well.
Thanks, Nino. And can I just clarify, when you say you're comfortable with a low level of pain, if we use the, you know, 0 to 10 point rating scale, if you were going to use that, where would you have your cutoff for that low level of pain?
Yeah, look, I guess it's somewhere between you know, a 0 to 3 out of 10 pain level. Terrific.
Thanks very much, Nino. Kylie, if we can come back and talk about your presentation, and it was a great presentation on an approach to how you can work towards return to play for an athlete. And the question here for you is that, you know, in the case where this athlete still had noticeable pain, can you explain or talk through the group how you address this with the athlete to help them return to play?
Thanks for the question, Scott. Yeah, look, I will say this is a really challenging decision because obviously being an adolescent athlete, we're looking at risk for her future health as well. And and returning to a very high risk injury sport, as we discussed with our statistics through the presentation. So from this perspective, we had extremely clear medical guidance. She had had serial CT imaging to actually clarify that her fracture indeed was healed, so the new fracture, and that the old fracture at the lower level of L5 was healed. So that gave us extreme reassurance from a biological perspective that we weren't dealing here with an active bone stress injury, which is a really important consideration. So from there, we looked then at actually monitoring her very carefully in the gym. So first of all, with a very graded approach to skills, which as I referenced, we looked at avoiding the extension-based and high-impact skills and introducing those in very low numbers, and educating her around monitoring of her pain levels. And you may argue that that, I guess, is a little at odds with a pain physiology approach, where we're really trying to not monitor pain so closely when we don't think it's the main driver in terms of tissue injury, being equivalent to further damage and the pain that it represents. However, we did feel this was still a really important consideration because of the high risk of the sport. So we did include education around pain physiology for the athlete. I briefly mentioned the YouTube clip that we did actually utilise was called Pain and What You Can Do About It in 10 Minutes, which is very easily searchable. And this is actually from a group that specifically looks at adolescent pain management processes, and I think actually represents a really nice tool in that space. Unfortunately, look, this athlete was very much on board with taking on that approach, so we were able to very carefully monitor her symptoms at rest and show her that her symptoms at rest were actually not different to those that she experienced when she did her loading in the gym, and we utilised that, so a level pain without any spikes in that, and a clear maintenance of her objective measures to then demonstrate to her that the loading in the gym was actually not progressing or changing her symptoms. So very much, I guess, an education process around pain physiology appropriate to the athlete, reassurance, and also education to her coach as well, because as I referenced, they were very concerned in regard to any symptoms that she was experiencing. So a collaborative approach, really underpinning that the tissue injury had healed, and that we were able to progress things because there are other variables that could influence her pain.
Thank you, Kylie. I really appreciate the follow-up there, and it's a great way to walk people through how to tease those different factors out. Kate, I've got another question for you, if I can. So one of the attendees has said that they've seen some researchers and clinicians that mentioned cushioned or supported shoes can actually weaken the foot and increase instability, and suggest that minimalist shoes can help to maintain or restore that function. Do you have any knowledge or opinion on this?
Thanks, Scott, and thanks for the question. I'll start with two things, really. There is a little bit of evidence potentially that certain shoes can reduce intrinsic muscle strength, and that's the second part, that it's intrinsic muscle strength, not extrinsic muscle strength. As far as I'm aware, I haven't seen anything that shows one kind or another of footwear increases or decreases extrinsic muscle strength to the foot. And I think we'd all agree that extrinsic muscle strength is much more important than intrinsic muscle strength for lateral ankle sprains. So my feeling is that the muscle weakness, intrinsic muscle weakness, is probably not a big factor. I think there'd be other factors with the shoes that can be a risk factor for ankle sprains, such as potentially the height of the heel, the flare of the heel, something along those lines. But I'd also say that sort of barefoot training, barefoot inspired training is certainly useful for a number of different parameters that could also influence sprains, such as, obviously the main one is somatosensory feedback. And I think most of us, for example, would probably do a lot of our balance rehab and so on barefoot. So I think that would speak to that side of things.
Terrific. Thanks, Kate. To our attendees, thank you for all the fantastic questions. We're running out of time. We will get to you afterwards, but I've got time for a couple more questions. Jackie, if I can come back to you. A similar theme to the last question, but would you recommend a different outcome measure for an individual athlete versus a team athlete? Is there an outcome measure that accurately measures external pressure in readiness or willingness to return?
Look, the answer is probably not too different. In that conversation is going to be our major thing. I think the difference that we would have with an individual athlete, as a practitioner, you've probably got to work a little bit harder to connect in with the other practitioners, whereas when you're with a team sport, you're often going to have them around you. So you'll get their more immediate feedback about what they're hearing from the athlete. So for an individual, I'll certainly chase up more feedback from the other practitioners, and I guess you might have closer monitoring with them. In terms of the external pressure, there's a couple of ways that I certainly look at it. One is if it's a high-profile sport or athlete, then you'll get some idea of, I guess, what's floating around in the media. But the other one is what you're hearing from the coaches, or just simply the dialogue and the self-talk that the athlete's giving you. Is they'll often be very forthcoming with their feelings of pressure if it's coming from somewhere, and that's where that relationship is so important. If you've developed that with them, that they'll be very honest and give you the best feedback they can there.
Terrific. Thank you, Jackie. Nino, if I can throw the final question of the evening up to you. Question from the audience, thanking you for a great presentation. Do you have any data or clinical thoughts regarding hamstring pain that may be related to hip joint pathology?
Not specifically to hip joint pathology, but I guess when considering the rehab of hamstring, you need to consider other areas, and the hip joint may be one, lumbar spine maybe the other. So you need to consider factors around that, and perhaps that probably would make it a more complex or difficult scenario to rehabilitate. But then when considering it as part of a return to sport plan, I think the criteria and the steps that you need to follow are the same, regardless of if it's an isolated hamstring injury or if other areas are involved. So you're still looking at all your clinical tests and then your functional tests and then on-field running and performance measures as well. But specifically to the hip, no, I'm sure it does play a part in it, but how it does probably varies as well, depending on the pathology.
Thank you, Nino. Appreciate you answering that question. Sonia, we're out of time, unfortunately. We've had some wonderful questions from the audience, but I'll hand back to you.
Thanks very much, Scott. Yes, it is time to draw the webinar to a close. And on that note, I'd like to say a final thank you to our speakers, the participants and the audience. And we do look forward to hearing your feedback from this evening. So please do complete the post-event survey when you get it. But mostly, we really hope you've achieved your aims this evening, which is, not to provide you a recipe to return to play, but to explore the complexity of the return to play decisions and hopefully share some of the tools and frameworks that you can use in your own practice. So thank you for being here this evening, and good evening.